Welcome to the Continuing Education module, Economic Effectiveness of Wellness Programming, Proving the Economic Value of Wellness. The agenda for this module includes a context for economic analysis, looking at the 5 key economic variables, overview of findings of major reviews, the Harvard meta-analysis, summary of economic evidence, reasonable expectations, and a summary of main points. Key terms for this particular area include economic return, which is the monetary benefit or savings associated with a programmatic activity like a wellness program. Return on investment, we're defining as the monetary benefit or savings, and that's the collective or summary of those savings associated with a program divided by the cost of that program expressed as a percent. So a return on investment of a wellness program would be in the area of perhaps 300% rates of return for a cost-benefit ratio of 3 to 1 in terms of its economic efficiency. The cost-benefit ratio is the monetary benefit savings associated with a program, and it's the same collective savings, depending on the range of economic variables that we're looking at, divided by the cost of that program expressed as an integer and or a decimal. And that usually is formed in the way of 1 colon to 3.2 or whatever the decimal is, that is the cost-benefit ratio. If you had a cost-benefit ratio of 3.6, you would have a return on investment of 360%. And finally, net present value is a financial method that is a commonly accepted way of estimating the time-adjusted net monetary benefit or savings associated with a program expressed as a dollar amount. So essentially, in a theoretical sense, any net present value over $1 would be a positive choice on the part of a business. But in general, the NPVs of wellness programs are estimated when they are not in place but are being proposed. And this particular methodology allows us to look at many of the literature-based findings applied to a specific wellness program for a specific organization. In looking at the economic efficiency of wellness programs, one of our concerns is the type of strategy or model, program model being used. And with a feel-good wellness program model, we're not likely to see it pay for itself in terms of having at least a one-to-one cost-benefit yield or the ability to pay back 100% of whatever the amount of investment is on it for a given time period. The traditional wellness program is generally in the area of about 3 to 1 in terms of cost-benefit return. So it's in the literature, there are approximately 12 programs that have been documented that would fit this particular model. And the way in which that 3 to 1 comes out is really the averaging of the cost-benefit yield reported in those peer review articles. Those particular articles also look at the cost-benefit yield of 3 to 1, which is equivalent to a 300% return on investment on an annual basis. The results-driven wellness model will generally produce a higher yield. So we oftentimes look at ranges around maybe 1 to 3.5 to 1 to 6.5 in terms of the amount of cost benefit. The return on investment would be 350% to approximately 650%. The issues of the design of an implementation are also important, meaning that the design has to follow some fairly carefully derived principles and concepts and guidelines and needs to be implemented in an effective way. The logical framework for ROI that we use is from some work originally done by D. Eddington, modified by the Chapman Institute, and it involves needs and targets of different types, And we can, in fact, identify those economic variables, the 5 economic variables that we think about with wellness, which includes health plan costs, sick leave absenteeism costs, workers' compensation cost, which is salary continuation and medical reimbursement, disability insurance costs, which are generally short-term disability and long-term disability, and the last area is usually presenteeism experience, which is the losses which occur in productivity and the value of that productivity in terms of compensation when the individual stays at work and has an underlying health problem that keeps he or she from being able to be as fully productive as they have the potential to be. So those 5 economic variables are oftentimes what we are capturing as metrics. We then are going through a planning process, which is part of what the core of the WellCert program teaches and advocates. And then a set of interventions usually comes out of that. And the interventions can be in the feel-good model, in the traditional program model, or in the results-driven model. Those are then implemented. Then a series of intermediate results are oftentimes tracked to be able to help establish attribution between the interventions that consist of the program and the ultimate results that we're looking at in terms of both return on investment and value on investment. So these intermediate results help us understand the changes that are going on. We want to see behavior change. We want to see health status measures change, and we want to see reported and self-reported assessments of productivity change. And our ultimate results are grouped here by return on investment, which shows you the 5 economic variables that we've talked about, and the other benefits, which are clustered under the value on investment. So these others have economic import for the organization, but generally are more difficult for us to monetize and to put in any kind of defensible financial analysis. And then at the bottom here you see the feedback loop, which is essentially something that takes place annually where we reassess what our results are, change our targets and or needs, help refine those, as well as refine our interventions, look for those intermediate results, and then again each year look at ultimate results in both ROI and VOI. Now the context issues for economic return are what savings are included. So which of the 5 variables are we looking at, economic variables? Who receives the savings associated with the program? Are they shared with employees? Are they entirely kept by management? Are they held in a way in which the risk or liability or potential liability of cost is in fact held by the organization? Are they self-insured for that liability? Or are they experience rated? Or are there other kinds of devices in place to share some of that future savings if in fact the health of the population is improved by a wellness program? Also, there's the issue of when does that savings occur? When do they actually receive a savings from a healthier workforce? Who pays for the program interventions? So if there are interventions which are necessary in order to improve the health of a population, and then the health of the population as it improves changes some of the economic parameters of worker health, then we have the issue of who is going to pay for the interventions that actually lead to improved health and well-being. We also have the context issue of how do they pay for it? Is it something that is essentially costed out in a given year, or is it depreciated against future kinds of costs or future kinds of economic issues and economic variables? So the issue of how do they pay for it comes into play. Also, what other types of savings and what other costs are included? So there are a wide range of costs that are associated with the work and work health of a working population. So we have the ways in which those savings are computed, and we have the issue of how extensive are the costs. Do we include, for instance, the costs that employees are encountering out of pocket as part of the potential savings from a wellness program? And are those measured in any way? So these are some of the context issues we have to resolve as we think about how economic return plays out from wellness activities with a given employer. Now, key economic variables are going to be health plan costs. Those can include prescription drug costs if they're in a separate supplemental plan, or if they're in a more comprehensive plan, it can include all of the hospitalization, physician care, emergency room care, clinical activity, rehab, home health services, a whole variety of kinds of issues that are covered by health plans, medical plans. It also you have the issue of whether you're going to include dental plans coverage and costs, or vision care plans or costs. So these are all a variety of things. Also, whether your COBRA expenses are included or examined in some sort of assessment. So those are all the different kinds of health plan costs. In addition, we have sick leave absenteeism cost, and if we have dedicated sick leave and we've done anything to create payouts where people take accrued sick leave and are given a payout at some point in time, then we generally can perform a financial analysis of that sick leave absenteeism difference. And in general, the 28 or so studies that have been done on sick leave show about a 25% reduction in the amount of sick leave once you do a wellness program. So it's thinking about how do you cost that out for your own organization. Also, we have situations where we have combined leave approaches, where we've taken sick leave and it's lost its designated category. We've put it in with other kinds of leave, and then we are essentially providing more leave opportunity, but giving employees more of an incentive to want to take better care of their health so that they don't have to use the sick leave. They then can use those leave days for vacation or for other desired uses. So there's some good effects of doing a paid time off or combined leave approach when we are looking at wellness, but we also then have to figure out how do we look at that sick leave absenteeism related cost. We also have things that are called oftentimes unscheduled leave, where the individual requests leave within 48 hours of actually taking it. And those tend to be good proxy measures of actual sick leave experience, both their own personal sick leave as well as sick leave that is taken for a sick family member. So those are some of the issues around our sick leave absenteeism and our conversion of those absences into monetary terms. The third major area or economic variable that we look at in the economics of worker health are workers' compensation costs. And again, about a third of workers' compensation costs are generally associated with medical reimbursement. It can go up and down depending on the level of wage and salary and the level of risk in a population. The other portion is usually salary and wage continuation while the individual is not able to work. So those are worker compensation costs. Disability management costs and insurance costs usually come in the form of short-term disability and long-term disability. So those are going to be a length of time where someone that's not able to work is in fact on disability because of that underlying injury or underlying health problem that's not work related. It does not trigger the workers' compensation category of cost, but it is in fact covered by private policies, insurance policies often, that are provided to organizations to help protect the financial well-being of employees that are not able to work for extended periods of time. Usually those begin anywhere from 10 to up to about 6 months for short term, and then usually 6 months to approximately 2 years for long term, although policy terms can vary depending on what the employer requests from their vendors. So that's a disability management related costs. A lot of those costs are oftentimes associated with automobile or vehicular injuries and or recreational sports injuries. The next area, the fifth area, is presenteeism cost. And presenteeism is essentially work loss productivity or productivity losses that occur when someone stays at work but has an underlying health problem like migraines or allergies or an upper respiratory infection or a joint pain or arthritis. There are about 45 to 50 different clinical symptoms and or conditions and or diseases that we generally associate with presenteeism losses. Presenteeism losses in general in the literature are reported to be usually anywhere from 2 to 4 times the amount that is spent on health plan costs. So it's a significant economic variable. The issue is that we don't pay a check or write out a check for it. So it is computed differently, but has the same and significant economic effect on organizations and businesses. So these are the key economic variables that we're looking at in terms of computing and determining what the economic return is from a wellness program. Each of these have been demonstrated in the literature extensively as being heavily affected by risk factors and behaviors that we tend to address in wellness programs. And they include physical fitness issues, they include tobacco use, weight management, obesity and overweight, diabetes, high and elevated blood pressure and or cholesterol levels, issues around the use of safety devices, things like seat belts, and a whole variety of other stress-related, depression-related kinds of issues. So we know that from the pretty extensive epidemiologic literature that all of the things that we address in wellness tend to affect all of these costs in a very positive way, meaning the more risk we have, the much higher all of these costs are. So as we change the risk profile in a population and lower the prevalence and the severity, we generally see significant reductions in all of these costs. So these are the primary economic variables that we advocate that you look at to be able to determine the economic effects on worker health of worker health interventions in general. And standard work units are another area that we can oftentimes use as an economic variable. The requirement, though, is that we have very standard units of work. And not that many organizations have very highly standardized output. So if you are processing claims, or if you're running a call center, or if you're doing any kind of procedure that is a very standard procedure in terms of work units required, then we can actually look at the work units that are produced and derive some economic benefit from those that's associated with the contribution the wellness program would in fact have. Now, a more authoritative meta-analysis is one done by several Harvard researchers, Catherine Backer, David Cutler, and Zuru Song are in the School of Public Health, the School of Economics, and the medical school, respectively. Their work in looking at 22 studies that looked at the peer review studies that looked at the medical costs associated with reductions with wellness programs. And then they also looked at 22 other studies, some of which were the same, because they looked at both sick leave effects and medical costs, and found what the reduction was from each dollar spent on wellness. And in summary, they found that the medical costs fall about $3.27 for every dollar spent on wellness programs in worksite settings, and that absenteeism costs fall by about $2.73 for every dollar spent. And when you combine those two, you essentially are looking at a cost benefit of around 1 to 6.0 or 1 to 600%. So these also are important for us because they utilize meta-analysis techniques which essentially take a large number of studies, take the basic data out of each study, put it into an assessment and analytic scheme that allows you to test out the assumptions on all the people that are in all the studies. So these are using techniques that are really used to refine our analysis of what these types of programs can in fact produce. So I would suggest to you that this particular study actually is a good study for us to recognize. It's done by people who don't have an interest in the field itself. They're not financially motivated to show good results or high level results, but they are in fact reporting on a core of the literature. It's not all the literature, but it's certainly a core of those peer review studies that have been done on these particular kinds of programs. They lack the randomization issue, which most researchers value highly, because the randomization of subjects helps us get to a more valid sense of what's really happening. But the reality is we can't do randomization in worksite settings because there are legal requirements against us randomizing subjects around benefits, and wellness is a benefit, or is considered a benefit. So those are some of the background issues, but I do believe that this particular authoritative meta-analysis is an excellent point for us, and reference point and data points for us around the economic return of these kinds of programs. We are going to look at other sources and do some summarization and some discussion of those as we continue through this module. Now, this is another summary that I prepared for the American Journal of Health Promotion. It was published in 2012. It included, at the time, 64 different studies. I now have compiled 110 studies, and I will be putting together an update of this in the next year or so. The organizations reporting these studies are listed on the list on the left, and there are 22 of them that are reported in this particular study. And it basically shows you that the traditional wellness program designs report out 10 studies reported out at about 3.0 cost benefit yield. So that's a 300% return on investment. The green ones are what I would call the newer programs with some of the newer prevention technology, using coaching, providing an e-health portal to coincide with the needs of the individuals around their wellness, issues around use of more of the trans-theoretical model, the readiness to change model, which is a more effective model for behavior change, as well as looking at things like medical self-care, the inclusion of consumer health issues in many of these studies between 11 and 19 in the listing. Those report an average return of 6.3. So they are producing a return of $6.30 to each dollar of cost, or 630% return on investment. The last three that you see are 20, 21, and 22. And those particular studies included reports that averaged 14.5 cost benefit yield, which means 1,450% return. Those are what I would consider to be outlier types of studies. And we don't oftentimes mention them that much, but number 20 involves a cardiac rehab use of a fitness training in a worksite setting, actually at the Coors Brewing facility in Golden, Colorado. That reported a 10.1 cost benefit return. 21 is the Aldana study of Washoe County, Nevada school district, and it reported a 15.6 cost benefit yield, and that was looking only at the sick leave effects. They did not find corresponding change in the health plan costs in their particular study. Study 22 is the Birmingham, Alabama 5-year study a more of a population health management model of programming, strong incentives for the completion of a wellness assessment, the involvement of coaching and coaches to help people reduce risk factors. They reported the highest actual cost benefit yield in the literature at 1940%. So theirs was the 1940 in that 22 study. If you took 20, 21, and 22, you essentially end up with the average of 14.5 cost benefit return, or 1,450% return. So again, our literature is varied. It depends on the models, and we consider these three at the end here as somewhat of an outlier experience. And we look at these in the green area as being more of the more recent, more newer types of programs and newer use of prevention technology. And the blue ones indicate our more traditional smorgasbord type of design. So I would probably put the results-driven wellness program toward the high end of the newer prevention technology programs. And depending on how many kinds of interventions and how many of the economic variables. These, by the way, almost all of these have been a single economic variable. So none of them included multiple variables. So we are looking at a very, actually a very under-measured, under-emphasized, under-weighted way of looking at economic return, because all of our direct costs of programming were always laid up against the economic variable that was being examined. And since most of these studies only looked at health plan cost, or only looked at sick leave, or only looked at disability costs, and didn't include multiple economic variables, they essentially are a significant undervaluing of what the economic return actually can be. At the same time, we don't want to put too high a bar out for people that are doing wellness, because employers that do wellness generally don't fund the programs adequately or do enough to produce all of the effect that the program has the potential to achieve. Now let's summarize the ROI evidence. We have essentially strong epidemiologic literature documenting the relationship of health risk to increased cost. And I would estimate that that literature probably numbers in the 400 plus peer review articles. So we have lots of epidemiologic literature that basically says that health risk of various kinds lead to increased cost. And those increased costs, by the way, are in health plan cost, sick leave absenteeism, workers' compensation, disability insurance costs, and presenteeism costs. We also have a strong demonstrated health risk causality and reversal effects in some 300 additional peer review articles. So we have the epidemiologic literature, which is really examining the relationship between health risk and health cost. We then have literature that is looking at these wellness programs and tracking the difference when you change health risk, and how we then change out the economic performance around worker health issues. We also have 15 or so review articles on the economic return of these kinds of programs. Almost all of them are very positive in their statements. We still have the difficulty, though, that they're without public funding of the research around the economic return issues. We don't have a good both methodological base to our research, or a entirely interest-free set of concerns for how those studies are interpreted and what the results are. So we do have that kind of issue facing us. Also, because we're working in worksite settings with employment contracts and employment and union issues, we are not able to randomly assign subjects to different experimental arms. So that takes away our randomized controlled clinical trial level of proof. But those 15 plus review articles still identify the significant trends that are demonstrated in those 300 to 400 articles that cover issues around the effects of wellness programs. We also have the meta-analysis that we just mentioned from the Harvard researchers. We also have consensus reports from groups like the American College of Occupational Environmental Medicine. So we have a number of groups that have essentially weighed in on what these kinds of programs have the potential to do in terms of economic effects. Now, the fundamental realities we're dealing with is we have employee health, which we know from the work of Dee Eddington and David Anderson and Ron Goetzel, that employee health naturally deteriorates without intervention. So if we don't have something that helps people age and well and not pick up the risk factors that kind of usually come with age, we are very likely to go from low risk to moderate risk to high risk. And so that happens naturally. Secondly, we have risk factors that are very prevalent in our populations and lead to significant amounts of chronic disease. And the amount of chronic disease, there are 15 chronic conditions that account for approximately 80% of all the chronic disease cost in the developed world. And in the U.S., our $3.2 trillion healthcare expenditures in 2015, 75% of those were due to chronic illness. So 80% of that 75% are related to 15 conditions, which are related back to 8 different risk factors that are at the core of what wellness attempts to change in working populations. So we have these risk factors that are very prevalent. They're highly associated with increased cost. They lead to chronic diseases. Chronic diseases account for that 70% of healthcare costs in general across the developed nations. Those same risk factors also drive sick leave, workers' comp, disability insurance, and presenteeism costs. And it approximates about $37,000 per employee per year, according to several of the major studies that have been published by Ron Goetzel, Jim Collins, and others in terms of Dow Chemical and some of the other major studies and methodological approaches to estimating those costs for working populations. So that's our national figure. Each organization needs to know its own numbers. Many wellness interventions reduce health risk factors. They help people change behavior and produce behavior change leading to reduced health costs. And we have more than 110 peer-reviewed studies that have demonstrated positive economic return from wellness programs. Doesn't mean that you can't find a couple studies that will in fact tell you that they don't produce much in the way of economic return. But when you look at those studies, you can find methodological problems and the fact that some types of intervention and implementation don't necessarily produce the behavior change which is associated with the increased economic return and level of economic return. So those are part of our considerations around this issue. Reasonable expectations are as follows. The usual outcomes, you usually can get somewhere between 35 and 95% participation depending on the type of model you're using and the type of implementation and execution skill you have. 10 to 35% increase in behavior change in particular areas. Physical behavior tends to be one of the most highly affected ones. We also end up finding other kinds of behavioral changes, nutrition changes, smoking related changes, use of e-health portals, use of tracking various activities, tracking body weight, for instance. 2 to 12% is the range of expected reduction in risk prevalence. And that's with our conventional wellness model, our traditional wellness program. We can get higher than that, but it takes more effort for us to get that. But if we're looking at reasonable expectations for a traditional wellness program is probably in that area of 2% to 12% reduction in specific risk issues. 17 to maybe 28% reduction in sick leave. 24% is probably the reported norm, or 25% rather, in terms of sick leave reduction. That equates to approximately 2 days of reduction of sick leave on a national level, where our sick leave average is around 8 days. So about 25% reduction. Somewhere between 0 and 47% reduction in per capita health plan costs. So we can look at some of the studies like the city of Birmingham and actually see up in the area of 50% reduction from the beginning of the 5-year period in actual per capita health plan costs. So that is in addition to the countering the medical trend that is going on, that is generally bumping up your cost anywhere from 6% up around 12% for very large employers, and then higher than that if you are a smaller than, say, 1,000 life employer. 15 to 25% reduction in per capita health cost medical trends. So if we have a trend of perhaps 12%, we can do a traditional wellness program and shave off 3 of those percentage points. So we can bring that 12 down to the 9%. We can also get much lower than that, but it depends on how much we're willing to do in order to affect all of those things besides risk reduction, which include things like medical self-care, consumer health education, advanced directives, ergonomics, injury prevention. So those are the other strategies that are going to be able to help us actually reduce per capita health plan expenditures in any population. And 20 to 40% reduction in workers' comp, disability days, and presenteeism levels. So that's what our studies, we only have probably about 12 to 13 studies that I'm aware of that are peer review studies in the workers' comp and disability days and presenteeism, but the ranges are fairly high. So the ability for us to change those. If we already have a lot of safety issues going on, and we've already done a lot of safety education, then we don't see as much effect from a wellness program. But we do have the potential to be able to reduce significantly those additional costs depending on what our starting point, our baseline is. And finally, a reasonable expectation, I think, is to look at a return on investment of a wellness program of somewhere between perhaps 1 to 0.7, so $1 of cost to $1.70 of benefit, to $1 of cost and $7.40 of return in terms of savings. So I think that in general, you can hit that particular segment. I've been all along those lines. I've produced everything from I think 2.3 is the lowest that I've ever been involved in, up to as high as 11.8. So you can in fact do a number of things to reduce costs, but again, it also relates to which of the economic variables you're looking at and how you have structured the interventions in the wellness program to address the specific economic issues that you're dealing with and want to affect. So those are some what I would consider fairly reasonable expectations to put out there around our efforts in worksite wellness. Now let's summarize the key points for this particular module. First of all, a consistent economic framework is important to the field of worksite wellness. So I believe we need to be looking at that framework. So we call it the results-driven wellness framework. And it basically starts out with targets and needs. There's a planning process that turns out and comes up with a set of interventions. You implement the interventions. There are a set of intermediate results which have behavior change, health status measures, and reported productivity as part of the things you're monitoring. And then you have some ultimate results, which are a set of return on investment economic variables and a set of value on investment issues as well. There is a potential of 5 separate economic variables that an employer can use to determine the economic return of a wellness program. I would use all 5, and I would determine what those costs are, when are they accrued, how do they get translated into my own organization's financial picture. Virtually no employer has used all 5 variables to determine the economic return from their wellness program. Almost all of the literature uses only one economic variable, and most of the time it's health plan costs. The second most frequent economic variable is sick leave. There is a significant amount of evidence about the increased cost associated with risk factors that wellness programs address. And we actually look at that. Another one of the modules here looks at the relationship between health risk and health cost, and examines many of the both seminal works that were done as well as current works that have determined and quantified some of those relationships. There are more than 100 peer-reviewed studies that have demonstrated the economic value of wellness and worksite wellness. A major meta-analysis from some Harvard economists establishes the clear economic benefit of worksite wellness programs. We still need additional studies on the economic return of wellness programs, and they continue to be published. A lot of them show up in the Journal of Occupational Environmental Medicine. Many of them also show up in the journal called Population Health Management. So those are the places where I would keep an eye on in terms of the newer studies. The economic rationale and economic evidence for worksite wellness programs are really extremely strong. I don't think you'll find a comparable level of economic analysis in virtually any other activity of business that is not required by law in some form. And this evidence needs much broader distribution and understanding by American business and government executives. It also needs help from the public sector to be able to provide research funds to actually demonstrate these things and demonstrate more appropriately what are the best practices that lead to the highest amount of economic return for different types of business and governmental and nonprofit organizations. Now let's cover some key questions about this particular topic. What are ideal characteristics of an employer that would likely have a strong economic interest in wellness? And first of all, the ones that I can think of are a high health plan costs. If you've done as many things as you can do to get your costs down, but you still have high health plan and medical plan cost, your medical trend tends to be at a higher level, an unacceptable level, that puts you into an ideal characteristic for someone that can benefit from wellness. If you have an aging population, perhaps your average age is greater than 42, that's likely to give you a lot of risk factors that you can work on to reduce costs. Also, a high risk prevalence. So if your population has a lot of different risk factors that have been proven to have a positive relationship or a direct relationship to increased healthcare costs, then that would put you in this ideal categorization. And if you're self-insured for those health plan costs, that would be another characteristic that would lead to a strong economic interest. If you are your production function is affected by employee absence. So if you can get along with people being absent without it having an adverse effect on your actual work productivity and work effectiveness or revenue generation activity, then that's going to put you into this high economic interest area. And if you have a dedicated sick leave program with a payout at retirement, and you want to reduce that unfunded liability associated with that future payout, that would be another characteristic that would put you in this economic interest area. And then also, if you're self-insured for workers' comp costs, or short-term disability or long-term disability, that would also provide an opportunity for you to emphasize and focus on these economic issues. And if you are more sophisticated in your capital management, if you're looking at things like the impact on capital management and you desire efficient ways of increasing profitability, if we have a self-insured medical plan and it's running at a cost of possibly $17,000 per employee per year, and we are doing wellness, each dollar we save in terms of claims in our medical plan has the potential to be a dollar of after-tax profitability. That's a choice that we make as business owners and business managers. If we were going to get a dollar of profit after-tax profitability from our sales process or the sale of our services and goods, that would require somewhere between $3 and probably $20 of sales in order to generate $1 of after-tax profitability with the usual margins, profit margins of most businesses. So if I have to go out and generate $20 or even $10 of sales to get $1 of after-tax profitability, I would be a lot better off as an organization going after reducing my health plan costs, where each dollar that I save in terms of claims can potentially become a dollar of after-tax profitability. So those are some of the issues that I think are part of the ideal characteristics associated with an employer that is likely to have a strong economic interest in wellness. Our next question is, for small employers, which of the economic variables would they likely emphasize? And if they are possibly in a health plan that requires wellness to be in that insurance pool, they would definitely have an interest in wellness. So they would be getting a lower premium, a preferred premium rate because they agreed to do wellness. If they also were in an experience rated or a retrospective adjustment kind of plan base or minimum premium plan base, then that would allow that small employer to be focused on their health plan costs. If they also had a dedicated sick leave approach with or without a carryover provision or a payout provision, that would also make them interested in the economic effects of wellness. And finally, the presenteeism losses, the ability for a smaller organization, a small business or medium-sized business to benefit from employees that are actually more productive when they are at work. And the measurement of that, which we have measurement methods and tools, that would also provide a rationale for them to be oriented to those particular economic variables. So in those particular cases, health plan costs, sick leave, and presenteeism are likely to be of more concern to the small employer. They're more likely also to be insured for be part of a state pool for workers' comp where there's no immediate benefit. Perhaps future rates might be lower or modifying factors might be more limited, or if they were covered by a disability insurance policy or a long-term, short-term policy, then that's usually going to be an insured situation as well. So they're not going to be as likely to use those particular economic variables in terms of looking at the economics of wellness for their organizations. The next question, question 3, is what changes in the business environment would increase management interest in wellness? And I can see several. First of all, if the trends around the revision, repeal, and changes to the ACA take place and continue to roll out as they are, the likelihood of higher health plan medical trends are likely to bring more interest in wellness. Also, if labor scarcity increases and we have difficulty recruiting, that will likely also bring a concern for that. In addition, if our workforce has a bimodal distribution where we have a lot of aging workers, and those workers have a lot of risk factors and a lot of cost, those would likely again bring more interest from management in wellness. And finally, if we have increased competition and competitive pressures from changes in our trade situation or changes in our markets, changes in our general economic system, that's where you would probably get more effectiveness in terms of management's interest in how wellness is done for their own employees and the employees' family members. Okay, now that you've finished this particular module, go ahead and take the quiz.